So now we're going to review some important EKG tracings of different arrhythmias. We'll start by discussing atrial fibrillation, talk about atrial flutter, then we'll talk about the ventricular arrhythmias such as ventricular fibrillation, and then we go in and talking about certain AV blocks, and we'll go through the arrhythmias that you may be tested on your Step 1 exam. So first let's discuss atrial fibrillation. Atrial fibrillation is a syndrome characterized by the atria fibrillating, as the name sounds like. Basically, there is no synchronization of atriomyocyte contraction. The atriomyocytes all behave on their own, contract on their own. There is no coordinated unit or synchronized coordinated unit that functions together like a normal heart would do. Now, as a result of this asynchronous atrial contraction, do you think that there will be a discernible P wave on the EKG? No, the P wave represents an atrial depolarization, or the electrical activity of a homogeneously contracting atria. And when all these atriomyocytes are contracting on their own, or depolarizing on their own, there's no P wave that's discernible on the EKG. So in general, or in AFib, a key EKG finding is that P waves are absent, or there are no discernible P waves. In addition to no discernible P waves, we see this irregular baseline of the EKG. This is another key finding in atrial fibrillation on the EKG. And finally, another important finding on the EKG is that there is an irregular heartbeat, or the RR intervals, or the time between each QRS complex, is very different, is variable. You can see RR1 does not equal RR2, does not equal RR3, does not equal RR4. There is irregular spacing between the QRS complex. So why do we see this? Why do we see this irregular spacing of the QRS complex? Well, the SA node is not setting the rate of depolarization because there is no sort of synchronized electrical depolarization originating in the atria and going to the AV node. So this basically means that the ventricles are getting randomly depolarized as there are different rates being picked up by the AV node. So the key EKG finding in atrial fibrillation is that there are absent P waves in addition to an irregular heartbeat, or QRS depolarization. The treatment of atrial fibrillation centers around rate and rhythm control. As we just described, both the rate and the rhythm are very abnormal in atrial fibrillation. In patients with atrial fibrillation, if the heart rate becomes too fast, say in the 150s, if the heart rate goes up into the 150s, stroke volume is actually compromised because there isn't enough time for the ventricle to fill and eject, so it ends up ejecting very small amounts of volume, which really impacts perfusion to our vital organs. So the key here is getting a control of the rate. So in order to slow down the rate, we really target the AV node. We do this by giving medications such as a beta blocker, or we can give calcium channel blockers or digoxin. This will result in a more controlled rate, and it's quite effective at slowing down the heart rate from 150 to a more appropriate range in the 90s to 100s. Rhythm control is not as important as rate control, but can be done in certain patients. The medications that we use are antiarrhythmics, most commonly class 1C or class 3 antiarrhythmics that are used to achieve rhythm control. If the patient is unstable, meaning they have chest pain, shortness of breath, altered mental status, or they're hypotensive, it's important to avoid all these medications and go straight to cardioversion, in which you can cardiovert the heart by sending a profound electrical pulse through the heart to reset the rate and rhythm of a fibrillating atrium. So another important concept of patients with atrial fibrillation is that oftentimes we anticoagulate them. Oftentimes we anticoagulate patients that have atrial fibrillation. Now why do we do that? Why are patients put on these very serious medications such as warfarin? Why do we do that? Well, it really comes down to the anatomy of the atrium. In the fibrillating atrium, what can happen is the atrium can dilate, can expand as a result of backflow or ineffective forward flow, and this results in stasis of blood. The key is here we have stasis of blood, where the blood isn't moving, which puts it at risk for forming clots. So if we remember back to Virchow's triad, the three risk factors for clotting include venous stasis or blood stasis, endothelial cell damage, and hypercoagulability in the form of congenital disorders or in the form of certain physiologic states that lead patients to have hypercoagulability. So in patients with atrial fibrillation, the key mechanism is stasis. The blood is sort of static in the atrium. The atrium is not contracting as a coordinated unit, so blood isn't moving as effectively from the atrium to the ventricle. As a result, this blood is at risk for forming clots. So if a clot forms in the atria, the worry is that it'll kind of branch off and embolize. Remember, we can have embolization from a thrombus in which the little bit of clot goes down into the left ventricle, and then from the left ventricle gets shot out through the aorta, and then, one example, go up through the carotid artery, enter the internal carotid, and create an embolus that blocks blood flow to a certain part of the brain, causing a stroke. So this is the real key downstream consequence of atrial fibrillation, the formation of thrombus within the left atrium that subsequently can form a clot and embolize and enter the microcirculation of our brain. So in order to reduce the risk of this happening, we anticoagulate patients. We give them warfarin. That is the main reason we anticoagulate patients that have atrial fibrillation. It's also important to remember that embolization can go other places besides the brain. It can embolize to the superior mesenteric artery and cause an ischemic bowel. It can embolize, clots can embolize to the common femoral artery and cause an ischemic limb. So you get the picture. Thrombus forming in the left atrium is a dangerous, dangerous thing. It is a result of long-standing untreated atrial fibrillation, and is the reason why we put these patients on heavy-duty drugs such as warfarin to prevent these complications and really life-changing consequences of embolization. Next we have atrial flutter. This is an abnormal, large anatomical electrical depolarization loop in the right atrium. You can see here. It is similar to atrial fibrillation, but also it's distinct because it really just focuses on the right atrium. We can see here that the atrium is contracting in a coordinated unit. We can see the P wave, so the electrical activity is appreciated on EKG, but it's depolarizing and contracting too fast. So for every time the atrium depolarizes, say for every 4 times the atrium depolarizes, the ventricle only depolarizes once. And that's this 4-to-1 ratio that we see here in this rhythm strip. This is referred to as a sawtooth pattern, and it is a pathognomonic sign of atrial flutter. It's important to distinguish from atrial fibrillation is that we do have discernible P waves. So there are discernible P waves that are fairly regularly spaced. We also have a regular spacing of our RR interval, which is different from atrial fibrillation. So the key here is, although there is atrial pathology and the electrical activity of the atrium is changed, the key is that it's not as severe or it's not as aberrant as atrial fibrillation. Atrial flutter in general is a benign condition unless it causes an increased heart rate that can compromise stroke volume and compromise forward flow. If the rate becomes too high, the rate of contraction becomes too high, say greater than 150 is a general rule, then these patients will benefit from certain medications or will benefit from ablation of this circuit with electricity to sort of break the circuit and cause a reduction in this increased heart rate that is compromising stroke volume. The next rhythm we're going to discuss is ventricular fibrillation. Ventricular fibrillation is a very dangerous and quite horrifying rhythm to see on an EKG. Now I will say, if you see this rhythm on an EKG, your patient is probably not doing so well, and you're going to have to act quickly. If you look at this rhythm strip, can you see any identifiable waveforms? No. There's no discernible cardiac rhythm. There's no QRS complex that you can make out. There's no PR interval. There's no P wave. In general, it looks like someone just took a crayon and randomly scribbled on the EKG strip. This is the key finding, or the key reading of a patient in ventricular fibrillation. And really, fundamentally, what we're describing with ventricular fibrillation is a ventricle, both left and right, completely behaving aberrantly. The cells of the ventricle are not working together. They're not working in a coordinated unit. They're fibrillating. It's like a bunch of spaghetti noodles moving around on their own, unable to generate a contractile force that would meaningfully move blood from the heart to the brain or to the gut or to our organs. So this is a rhythm that is not compatible with life, and your patient will not do well unless you act quickly to fix this rhythm. So ventricular fibrillation usually starts from ventricular tachycardia, when the depolarizations of the ventricle are happening so fast that you eventually get these ionic imbalances that lead to disruption of synchronization. We develop these multiple reentrant circuits where these sort of cardiomyocytes form sort of teams and they don't work together and they all kind of contract on their own so that there is no coordinated effort. And in reality, this is very similar to atrial fibrillation, yet now it's happening in the ventricle, which is a little more concerning. When you see somebody with this rhythm, it's very important to, number one, call a code blue, find an AED or a defibrillator, and immediately begin CPR. This is a shockable rhythm. This is a shockable rhythm that can be reverted or fixed if you get an AED and you deliver a defibrillation to the heart. Defibrillation will essentially wipe out the electrical activity or this fibrillating electrical activity of the heart, and it will allow the heart to reset, essentially, and allow the sinoatrial node to reestablish its dominance and cause a normal, regular, coordinated heartbeat once again. So now we're going to discuss the different forms of AV blocks, or atrioventricular blocks. These are conduction abnormalities focused on the AV node in which there is some form of block in the AV node leading to a prolonged PR interval. So the key EKG finding in an AV block is prolonged PR interval. Now, do you remember how long the PR interval is normally? The PR interval ranges from 0.12 to 0.21 seconds. The way I remember this is that the numbers just flop and switch between the low end of normal and the high end of normal. You just switch the 2 and the 1 and you get the normal PR interval. Now, what does the PR interval represent again? The PR interval is that period of isoelectricity on the EKG that exists between the onset of the P wave and the onset of the R wave, or the appreciation of the R wave. Essentially, this is the time between atrial depolarization and ventricular depolarization, the period where the AV node is involved. If you remember, so the depolarization starts in the SA node, spreads to the atrium, then goes to the AV node, and then further goes through the ventricles. So the key here is there's something wrong with the AV node that delays or interrupts the conductance, resulting in a prolonged PR interval. The blocks are broken down into various degrees that increase in severity. You have first degree AV block, you have second degree AV block, you have third degree AV block. And there are two types of second degree, which we'll go into, type 1 and type 2. But the key is that first degree is relatively benign. There's nothing much to do. Second degree can be benign or can be pathologic or harmful. And then third degree is quite harmful and usually requires intervention. A first degree AV block is seen when there is a temporary slowdown of conduction through the AV node. It's a temporary slowdown of conduction through the AV node. It is defined by a PR interval greater than 210 or greater than 0.21. That is it. All the PR intervals are generally the same length. You can see here they're all the same length and they're greater than 0.21. That's it. It is a benign condition. It's usually asymptomatic and there's nothing we really need to do. All there is a prolonged PR interval, meaning the electricity is staying in the AV node for longer than normal. That's it. The next AV block, or second degree AV block, is broken up into two types. Here we have type 1, Mobitz type 1, it's also known as the Wenckebach phenomenon. So this, in comparison to first degree AV block, is a bit more severe, and really it has to, the changes from the first degree AV block is that the PR intervals are variable, and we see dropped QRS waves. So the key here is that the PR interval is greater than normal, it's greater than 0.21, but we also see that as it progresses from beat to beat, the PR interval gets longer. We can see that PR2 is greater than PR1, 3 is greater than 2, and 4 is greater than 3. So as we progress from beat to beat, the PR interval increases, so it gets longer, and at some point, the entire QRS complex is completely absent. It's completely dropped. And that is the key to this Mobitz type 1 or Wenckebach phenomenon, is that we see a gradual increase in PR interval from beat to beat, followed by a drop in the QRS complex. Second degree AV block Mobitz type 2 is slightly different than Mobitz type 1 in the fact that the PR interval is actually the same from beat to beat. There is no gradual regular increase that we see in the Mobitz type 1. What we do see though is we see that there are random absent QRS complexes. So we see this PR interval that is the same from beat to beat, but we see these randomly dropped QRS complex. We can see a P wave here without a corresponding QRS complex. So essentially what happens is that the electricity fizzles out here in the bundle of His and doesn't move on into the Purkinje fibers, and there is no QRS complex or ventricular depolarization. This is usually caused by fibrotic changes in the bundle of His. It's much more aberrant, there's randomly dropped QRS depolarizations, and this can be a very risky and dangerous situation. The way we treat this is we actually give these patients pacemakers. They need pacemakers in order to make sure that they're not dropping all these QRS complexes and not significantly decreasing or compromising their cardiac output. Unfortunately, the majority of these patients with Mobitz type 2 second degree AV block progress to third degree AV block, which is the most dangerous of the atrioventricular blocks. Third degree AV block, also known as complete atrioventricular block, is when there is absolutely no communication between the atrium and the ventricles. They are now completely distinct electrical systems because there is complete blockage of the AV node. Remember, the AV node is in an anatomically normal heart is the only communication between the atrium and the ventricle. I'm saying that assuming there's no accessory pathways like in Wolff-Parkinson-White. The only electrical connection between the atrium and the ventricle is the AV node and the bundle of His. So in type 3, we see an absolute complete dissociation of electrical activity between the ventricle and the atrium, and these waves are completely dissociated. The P and the QRS wave are completely dissociated, and there is no sort of coordinated contraction of the atrium and ventricle. Remember, there needs to be some coordination because the atrium is pumping blood, contracting blood into the ventricle, that's then contracting blood to the rest of the body or into the lungs. And if these do not coordinate or do not communicate, then there's just sort of this random contraction and ultimately a compromisation of the cardiac output. So the key EKG findings are normal P waves. We can see that the P intervals, or the interval between the start of the P wave and the start of the next P wave, are normal. They're fine. There's nothing wrong with the atrial conduction. There's discernible P waves. The atrium are contracting in a regular manner. The key is that we can see that there are QRS complexes just scattered around randomly. They're not following a P wave like normal. They can actually occur on top of a P wave. Here we see a QRX complex and a P wave occurring at the exact same time. Here we see a P wave on top of a T wave. So you can really see there's absolutely no coordination between the ventricle and the atrium. And we see the QRS and P waves just really happening at random times. So as you can imagine, this is a very serious problem, and patients with this third degree AV block generally don't generate enough cardiac output to perfuse their vital organs. So an extremely high yield association for your step 1 exam is to remember that third degree heart block is associated with Lyme disease. Now, can you remember what spirochete is responsible for Lyme disease? Borrelia burgdorferi, very good. And now how does this result in third degree heart block? How does an infection by the spirochete result in such a dramatic dysfunction of the electrical conductivity of our heart? Well, in advanced stages of Lyme disease, spirochetes disseminate throughout the blood over the entire body. In particular, they can enter in the heart. As a result, we have our immune system, who's readily prepared to fight off the spirochete, come into the heart and cause a local inflammatory response that leads to fibrosis and inflammatory damage of cardiac tissue and really ultimately messing up our cardiac conduction system. So really it is our own body's immune response that really damages our heart and causes problems with electrical conductivity, leading to third degree or complete AV nodal block. So now let's move on to a flash quiz. In what type of heart block do the atria and ventricles beat independently from each other? That would be third degree heart block. Very good. So now time for a test yourself question. I want you to read the question and take some time to think about it before we go over it. I'll read it out loud. A 24-year-old woman presents to her physician following a bout of heart palpitations. She states that she recently felt dizzy and passed out. She has experienced similar episodes in the past. On examination, her blood pressure is 130/90 and her heart rate is 85 beats per minute. An EKG is performed that shows wide QRS complexes associated with relatively short PR intervals and slurring of initial parts of the QRS complex. What is the etiology of this diagnosis? So let's go back and think about this patient that we're seeing in front of us. This is a patient who's having palpitations, so we can guess that she's having some sort of cardiac issue. And these palpitations are severe enough where she's feeling dizzy and she's actually having a syncopal episode. Really, the game changer and the critical part of this vignette is their EKG description. The EKG description gives us an idea that there is something going on with the QRS complex and the PR interval. Now think about some of the pathologies or arrhythmias that we just spoke about or are discussed in other parts of the lecture that resemble this sort of description. Well, what they're getting at here is they're trying to describe a delta wave. They're describing a delta wave that is seen in Wolff-Parkinson-White syndrome. So the answer in this question is B. The etiology of this syndrome is an atrioventricular bypass tract or an accessory conduction pathway seen in Wolff-Parkinson-White. What they're describing here is a shortened PR interval as a result of this delta wave that is caused, or the electrical activity as a result of this accessory conduction pathway. So this is sort of how board examiners will test you on exam day. They will describe a patient who has clinical signs and symptoms that will get you to think about heart disease, and then they'll give you some descriptions of an EKG, or they'll show you an EKG, and they'll ask you for a diagnosis or the pathologic problem that causes the particular diagnosis. So in this case, the diagnosis is likely Wolff-Parkinson-White, and that is caused by an atrioventricular bypass tract.